I just want to welcome everybody to today's webinar. This is an opportunity that the LMC has kind of been able to gather Healthwatch with us today to talk about the Enter View visits. We hope it's a kind of an informal session that kind of gives practitioners the opportunity to understand more about the Healthwatch Enter View visits, how to get the best out of them, and kind of what they entail. We've kindly been joined by Gemma and Donna today, and I'll pass over shortly to for them to kind of take this forward. But if you have any questions, please feel free to raise your hands or put the questions kind of in the chat. We will be waiting for other people to come through, so as and when we'll let them in. So Gemma and Donna, if I'm happy to pass over to you to introduce yourselves and start the webinar, if that's okay.
Excellent, thank you. Hi all, my name is Gemma Barrow. I'm a Healthwatch manager and I cover Healthwatch Leicester and Leicestershire. My colleague Donna, she leads on the Enter View programme, and she also works closely to lead our volunteer programme as well. So we're here today and I'm going to give you a brief overview of Healthwatch, who we are and what we do. And then Donna's going to explain a bit more in depth about the Enter View programme. So Donna is going to load up the slides for me. We're doing a double act. So I will start off and then Donna will talk through the programme.
Can everyone see my screen?
Yeah. You just start the slide.
Yes, I can. Donna. Yes, I can.
Yeah.
You start that.
Okay. Yeah.
Brilliant. So we'll start with what is Healthwatch. So for those of you who may not know who we are and what we do, we are your local patient champion. Our role is we are the voice of local people, and we're there to help people share what matters most to them, what they think works well with their local healthcare, what doesn't work so well, and where they want to see improvements. So we are a national and local patient champion. So we have Healthwatch England, who are based down in London, and across England there are currently, I think it's 152 local Healthwatches. For in our local area, we cover Leicester, Leicestershire, there's Healthwatch Rutland, Nottingham, Nottinghamshire, etc. So we're independent, but we have statutory functions. So what that means is we can determine our work programme, we set our priorities every year to look and see, well, what does matter most to local people? Where are we best to gather some intelligence, get some feedback? Where are we best to kind of talk to what matters most to the people in Leicester and Leicestershire? And it is different. So we've got two very different areas that we cover, one very urban area, one very rural area. And then what we do is we do various activities, including Enter View. We do outreach, we do projects, and we're there to kind of then share our findings with the local system to say, here are some insights and some areas of improvements. And we may make recommendations. And as a statutory body, we will hold the system to account. So we have our board members, local volunteers who get involved to sit on those boards to kind of challenge the system and say, well, have you thought about this? Have you thought about that? Here are some of the things we've found out. Next slide. So what is our vision? So our collective vision across all local Healthwatches is to bring close the day where everyone gets the care their needs. And we want to make sure that people's experiences help make health and care better. And I won't read through all our values, but we'll share this with you as well. But in essence, we are the patient and public voice. We are there to make sure that within all the different areas of the health and care system, the patient's at the heart of it. Next slide. So again, as I mentioned, this is just a kind of overview of how many people are actually involved in the Healthwatch network. So within Healthwatch England, so the national body, there's about 40 people who work in Healthwatch, and then across the 152 local Healthwatch, 153. We might have added one. They might have changed one up. We have volunteers, we have staff, and there's roughly about 4 staff per Healthwatch. What are some of the kind of things we do? Say, Enter View we're going to talk about, but we also do an information and signposting service. So people can get in touch with us 9 to 4, Monday to Friday, and we'll help people with their issues and concerns. We don't deal with complaints. Any complaints we refer to independence complaint advocacy, whether that's PALS, PILS, or Power Advocacy. We go out a lot. We have our community team and we go and do events. We do lots of public engagement, working closely with our local community, doing partnerships. We do research projects on areas that matter most. And as I said, we represent public voice and influence through our relationship and attendance at strategic meetings. So I just wanted to give a few examples of some of the work we've been doing to give you a flavour of it, some of the things we do. So over the last year, we've done some work around supported living services, trying to find out about people's experience of healthcare and does their living situation affect how they interact with health services. We do a lot of work at the hospitals, and we'll talk about some of this as part of Enter View. And we've got an example to share with you around our work that we've done within adults emergency department and services. We've done a big piece of work around eye care services. So this is not just locally, it's national as well. So we want to find out what people think of eye care services and how they're functioning. We go out and about a lot. So we put down, we've been at, last summer, we were at 83 different summer events and speaking directly to people and gathering all their feedback. Slide, Donna. On World Mental Health Day, we went to Mount Sorrel Quarry because, again, we want to engage with people who are working. Sometimes we don't get to reach people who are working, one of the hardest groups to reach. So we're trying to get into more workplaces. The Enter View team, I put a list there of some of the, so we do visits to GP practices, care homes, and I say some of the services that we've been to. So the CAM service, hospital wards, the ED department, and we've published reports with recommendations against those. We are trying to reach as many people as we can. We work with all communities. So we try to make sure that all communities are represented within the work we do. And we've done some targeted work with surveys on trans and non-binary individuals' experiences with GP services. We've had a good response to that locally, and that's part of a national project. So just a flavour, I just want to give a flavour of some of our work. So Dawna's now going to give you a bit more of an in-depth into the Enter View programme.
Hi everyone, can everyone hear me well? Because I can't see everyone. So in the Enter View programme, so what is Enter View? So local Healthwatch have powers of entry and providers have a duty to allow entry if local Healthwatch operate under the principles of legislation set out below. So it gives us, so we go into health and social care premises to hear and see how people experience the service. We collect the views of service users, so that's patients and residents at the point of service delivery. So on the day, observation, at that moment of in time, we collect those views of those service users. To collect the views of carers and relatives of service users, to observe the nature and quality of services, that's involving all senses. We collate evidence-based feedback, and then we report to providers, regulators, local authority, NHS commissioners and quality assurers, the public, Healthwatch England and any other relevant partners. This is to develop insight and recommendations across multiple visits to inform strategic decision making at local and national level. Where does Enter View apply? So the guiding principle, the legislation allows Enter View activity to be undertaken on premises where health and social care is publicly funded. So that's your NHS Trust, NHS Foundation Trust, local authorities, your primary medical services, that's such as your GP surgeries, primary dental services, your dentists, primary ophthalmic services, pharmaceutical services such as community pharmacists, premises which have are contracted by local authorities or the NHS to provide healthcare services such as adult social care homes and daycare centres. So deciding to make a visit, so it's not just picking out names out of a hat, as some people like to ask me, is that what you do? No. So we respond to local intelligence at a single premises. So our outreach team will attend various events around the city and in the county, where people from all different communities will share their experience about health and social care services. We've also had requests from stakeholders. So UHL, they've requested for us to go into the gynecology services at Leicester Earl Infirmary and Leicester General Hospital. We've also been visiting wards at Leicester Infirmary, gathering experience from patients with learning disabilities. Following our visits, we provided an independent report recommendation from themes that emerged from the experiences shared on that day. The process. So the process for Enter View. So when we visit, so Enter View visits can be announced or unannounced, and services will typically be notified in advance of a visit. Unannounced visits will only be made in exceptional circumstances. Who visits, so who conducts all the visits? They are conducted by our trained Healthwatch Leicester and Healthwatch Leicestershire volunteers. They're called authorised representatives. Our representatives are independent from staff at health and care services. The visit outcome. So it is important to note that entry and view visits are not inspections. Entry and view visits are about listening to experiences rather than being an in-depth formal investigation. They are a regular person's perspective of health and social care services. The visits aim to give a voice to service users, their families and carers, members of the public and staff to have a say on how the services are running and what could be improved. And also just like to add that the report, but the findings are all reported by the authorised representatives of the visits who are on that day. So the report isn't done by anybody else, it is done by the visit team. So this is just a little timeline example of the announced entry and view visit. So how long the process usually sort of takes. It can, so starting off the process of the visit is the lead entry and view rep to contact services to book visits, then letting the representatives know, then it's sending letters out, posters out to the services, informing of our visit of the date and time. So all that can take a bit of time. Then the day of the visit, and then the report writing can also take quite a while to ensure that we've captured everything from the visit. And again, getting the response back from the service provider, we give the service provider about 21 days to respond. Sometimes they may need additional time to respond to the report. So again, it does take a bit of time. What happens after an entry and view visit? So following the visit, we collect feedback and produce a report with recommendations. The report is shared only between Healthwatch and the provider before being published. The provider is asked to check for factual accuracy and to provide comments on the recommendations. These reports are then shared via our website and with services, planners and regulators, as well as stakeholders such as Healthwatch England. And this is a great chance for services to learn about what is valued within their organisation and what could be improved. So entry and view LRI, the Adult Emergency Department, 1 year on. So we visited the Leicester Royal Infirmary Adults Emergency Department in September 2022 to observe the department and listen to patient experiences. These findings were presented to University Hospital Leicester to assist them with improving the patient experience at the emergency department. In September 2023, we revisited this project and further engaged with people in the department. We conducted on-site observation and engaged with ED patients to gather first-hand experiences and insights. We were there for the full day, so it was from 7 a.m. till 7 p.m. The findings from the 2022 visits were compiled into a report which included 16 recommendations aimed at enhancing various aspects of patient care within the ED. These recommendations served as a framework for evaluating the progress made during the revisit in 2023. The recommendations encompassed a wide range of areas, including improving waiting area facilities, communication strategies, patient assistance protocols, and accessibility measures. What difference did this make? So our research led to a proactive response from UHL, and significant efforts were made to improve patient flows and address identified issues. The 2023 revisit highlighted areas of progress while also identifying areas requiring continued attention and improvement. By actively engaging with patients and implementing targeted recommendations, significant steps have been made to improve the overall patient experience within the ED. The UHL action plan showing progress updates on our recommendations is detailed in the full report, which you can find on our website. And this is just something that Richard Mitchell had left a response in regards to the report, so you can have a read when we share the slides. How do entry and view visits benefit services? So it gives services the chance to receive independent, unbiased feedback on what service users, patients and staff really think. Visits let services know where there could be improvements to consider and what is valued. It's an opportunity to showcase and share good practice, which is an important part of the feedback report. It shows the CQC who receive our reports and other regulators that services listen to patients about their experiences. Engaging with us helps services to engage a wider perspective. This is through life experience, common sense, and being in touch with service users and the local community. And this is just what we for our volunteering opportunities for people to get involved in. So people can be community champions, they can become authorised representatives, they can sign up to our newsletters to get our quarterly newsletters, surveys, information. People can do guest speaking as well. And this is just our information. If anybody wants to get in touch with us, we have our address, email address, contact number and email there. Okay, and I think that's the end of the slide.
Thanks, Donna. I was just going to add in for everybody, because obviously around the GP practices that we go and enter, review and visit, one of the things we do is we also get in touch with the PPGs before the visits, because, you know, it's really valuable to meet and have conversations to see what PPGs want to share, because it's a good example of showing what's going well, where there's good relationships, what's working, again, where they think improvements might need to be made. So we make sure it's a very a rounded process. And at the end of a visit, wherever we are, we always will meet with the practice managers or the service provider who we're with on the day to tell them what those recommendations are going to be. They're not secretive, they're not hidden, they're observations from that day. So they're aware of what will be going into the report. So it's nothing is kind of there to kind of trip anybody up. We are there because we are there as observers. We are there to provide insights and to give layperson's perspective. And then if there is anything, so there have been instances where, particularly more in care homes, so if there is something that happens, or if there's a safeguarding concern, or if there's something we feel that needs to be escalated, we will escalate it to the Care Quality Commission, because they may go and have an inspection. And we do also triangulate. So Donna attends information sharing meetings to make sure that we are working within the system as well. So we work closely with colleagues to see, and CQC colleagues to know where they're going, so we're not stepping on each other's toes, because there's, you know, time, energy, efforts and resources. So if we're going to do an inspection somewhere, we may not do an enter review visit at that time, but we will always feed in our intelligence. So we get asked very regularly, have we had any information? Do we have any insights? Do we have anything to share about a particular practice or care home? So the relationship is there really strongly, that feeds through the system. So I just wanted to add that in case any questions.
I've actually got a few, but I wanted to give obviously other people the opportunity to kind of speak first. If we haven't got any active hands, I might just ask a couple of questions which might kind of stem a kind of thing. So you talked about at the beginning about you kind of go on intelligence of where you kind of then conduct your kind of visits. Can you kind of outline what intelligence you kind of use so practices are kind of aware?
Yeah, so as we say, we go out a lot. So we're all over. We've got 3 dedicated community outreach officers, 1 for the city and 2 for the county. So a lot of the time they may go out. So say, for example, Melton's probably a good example. So if we go out somewhere in Melton, we're going to hear a lot about Latham House, for example. You know, people are going to share information. So so our team will gather that intelligence. So we use feedback cards. So people might share to us, I've got an experience at my GP, and, we'll always ask them, is it a positive? Is it a negative experience? What are the issues? What are the concerns? And so what we do is, because we're always looking for themes and trends, so we don't deal in complaints. So if people have got, like I said, individual complaint, we'll advise them how they can resolve that, go back to the practice, whatever it might be. But if we start to see a theme and a trend, so if people say we've gone out to Melton, for example, over a couple of weeks, couple of months, and suddenly my outreach officer might say, and we'll get the information and go, there's a pattern emerging here, and we'll say, what is the issue? And they're saying that people are saying that there's never any appointments, for example, they can't access the GP. It's our common topic, we can't access. Or somebody might say there seems to be a particular issue going on with people who are trying to access X or Y, and that's what we look at. So a live example actually is we went to the Highfield Centre. So there was an event on at the Highfield Centre, so in the city centre. We went along and we spoke to people, and a lot of people were talking about the local GP practice and some of the issues and concerns. So we've got some issues there. Then we looked at our own data. What do we already hold on this? Is there a pattern and trend emerging? Then we spoke to some of the system leads. So to say, have you heard anything about this? So we work with our neighbourhood mental health leads. We work with the local area coordinators. We asked them, have you heard anything on this? And then we decided, based on that intelligence, we're going to go and do a visit. And it was actually, Dawn went on the visit, and report is imminent, but it was a really, really positive visit, because although we were hearing quite a lot of negativity from people, not all bad, but there was a definite upset about issues. But after visiting and getting some responses from the practice, that report has shed some really good insights for patients to say, this is your issue and this is why you may or may not be able to do it for various reasons. Sometimes it's the building itself. You can't magic up more space that you need. You can't create, especially practices don't own the buildings. They have limitations on what they can do. So all of that will go into the report because the team went on the day. We also do use, so for GPs, we also use the GP text messaging service because since COVID, obviously people aren't sitting as long or in the waiting rooms as long as they used to be, say. So one of the things we try to do, and it is always within the same time period, is we will ask practices to send a short survey out. So we're working with our ICB colleagues to just refresh that survey in light of, general changes to GP practices, so that those who we don't encounter on the day also get the chance to tell us a bit about that service. But we're always looking for, people's honest opinions on it. We're not looking to ask people what doesn't work. We're also saying, well, tell us what do you like about things? What works well for you? Because that's important as well. So it's there's a lot of different angles for different services. So it's like Donna was saying that, we may get requested. So with the hospitals, we may get requested, and then we look at the data, say, okay, what have we already got on this? Is this an emerging issue? Is this an emerging concern for us? Like CAMS is always on our radar. So we had the opportunity because the beacon was built during COVID, and then we took opportunities to go and visit. So yeah, lots of different reasons, but again, specifically with GPs, it's always based on intelligence.
Okay, that's really useful to know, Gemma. There's a few kind of other questions. You talked about obviously arranging a time and a date. I presume there's obviously kind of flexibility within
Absolutely.
It's not kind of like we're coming out on this date and we'll be here. So because obviously within staffing, within kind of general practice changes all the time. And just as a general kind of overview, so if you kind of arrange a visit, how long? I know what the example, the case study you used was UHL, and that seemed to kind of a very significantly kind of long period. What is the kind of general when you kind of go into general practice?
So
a day, an hour, 2 hours?
We will spend half a day normally. So it's normally a 2 to 3 hour visit, dependent on. So one of the key things is when we go in. So again, exactly that. So Dora will make contact with the practice manager. So that's first thing, have a conversation about we'd like to come and visit. And our first thing is always ask, is there any days and times to avoid? Because things happen, might not be open. Care homes are one where we get a lot of people cancel because of things happen at the care home. So we have to rearrange. They might have a COVID outbreak, they might have people not well, or it's just no longer convenient. So we will work with providers. So doing a lot of that relationship, working back and forth with the providers. And yes, we will then set a date and a time, and it'll either be a morning or an afternoon or an evening, depending, because we do go out in the evenings and we do go at the weekends. So depending on what's appropriate for the service. And obviously then we will have our visit team in place. And normally a visit team is 2 to 3 people, especially for GP practice. So it's not onerous in a sense of you're going to have a load of people coming in. It's normally a couple of people, 3 maximum, depending on the size of the practice itself or the service we're visiting. We then, the process is that we ask on the day, because the practice manager will be aware we're coming, and we ask that they obviously make the team that's going to be there aware that we are coming onto site. Then normally what happens is receptionists will greet us, and obviously the practice manager will come and see us. We just ask for the lay of the land. So the key thing is we do not need anybody with us during the visit, essentially, because we are only going to patient or public areas. So, for example, we don't need to go into medical rooms. We don't need to go into people's bedrooms, say with care homes. We don't need to go into store cupboards where the laundry's kept, anything like that. We do not need to go anywhere that is not accessed by the patient. So that's our key focus always, patient areas only. And then once we've kind of done the introductions, we will conduct our visit. And then the visit team will come together. They normally take about 5-10 minutes because they're noting down all the time of that visit to kind of say, well, what have we found? What are some of our key recommendations going to be? Now, sometimes it can go either way. We might only have a handful of recommendations. So it might be 5 key things. Sometimes it's about 20 if it's something that we've gone, services normally. There's sometimes quite a few things for us to observe. and to feed back on. And it depends on the scale of the visit as well. But normally GP practice, I think, Donna, we have about anywhere between 3 to 8 recommendations on average. Very similar setup and process. If the PPG members have managed to come along on the day, we set aside some time to then have a conversation with the PPG members, which is great. And then at the end, like I say, there's the feedback session. So that's the opportunity for the representatives to share with practice managers what they've observed and to give them a kind of indication, because sometimes some of the things we observe get resolved on the day. There can be things that just are, signage. Oh, we didn't spot this sign, and they'll say, yeah, it's here. And we go out, we look at it, and we go, it's kind of hidden behind a bush, maybe, something small, but actually would make a difference. It can be an issue with the toilet. So we sometimes have some of our representatives will go in and check. So we sometimes have people in wheelchairs, so sometimes they'll go check, and the door sometimes the toilet doors don't close, or there's a massive gap if you're trying to get your wheelchair in. So we notice things like that as well. So how is the accessibility? Are there any obstacles in the way? What is the information for patients like? So all of these things they will feed back on. And I say sometimes some things do get resolved there and then, because you can go, we didn't notice. Oh yeah, now you see it, because that's what they're there for. They're doing a layperson's perspective on things. I mean, sometimes I think when Donna was at the ED visit, somebody, I know this sounds daft, but somebody had left out a spill, a hazard, some of those hazard signs, which could be dangerous for people. So things that we spot on the day, we will also report on, as well as the bigger things. I mean, one of the things with the ED work, and I don't know anyone who's been to ED recently, but we've been working for years on some of the way the number system. So if anyone's been there, I always talk about this, it's always my example, because it's the one that really irked me with the number system. When you ever get down to ED, you get given a number, and then what people used to do is watch the number on the screen move. Like you're in a queuing system and everyone's watching their number, waiting for it to get to the top. And then all of a sudden your number drops off the screen or it moves, and people go, what happened? And then they go and ask and say, because it starts to confuse patients, because actually the numbers didn't mean anything to patients. It was an internal number system. So one of the things we asked UHL is now the case is saying, why are you displaying that to patients then? Because it's confusing patients, it makes them anxious, it makes them ask questions. And so now you get a number, but it's not on that screen anymore because it doesn't mean anything for patients. So there's things like that where we look at, the environment issues. People want to go to the toilet, they're scared to go to the toilet, and it's like, well, how can we make this work for patients? How do they know how to do some of this process? So yeah.
So you obviously say you have a kind of a series of recommendations that you kind of publish within the report.
Yeah.
Is there any kind of mandatory for the practice to kind of complete those recommendations?
Nope.
Or do you kind of go back to kind of check?
Yeah, we go back. So in terms of, as we say, when we do the report, the one thing we always ask is for the factual accuracy, that we make sure it's between us and providers that it's correct. Now with the recommendations, the recommendations are not there to be something that you're never going to complete. You know what I mean? Like, it's about just their observations. So it's up to the practices, because it's for their patients, it's for going out to the public about, we've spotted this. Is there anything you might already be doing something on it? You might say, well, actually, we get a lot of time, especially with GP practice, where the practices will tell us, this is happening, we're working on this. And we put all of that response in the report, because Enter View is about your right to respond to that. You might, some people respond directly to each recommendation. Some people just give us a statement. Well, say, thank you for our visit, we recognise and they might just put a statement in there. It's not mandatory to respond. A lot of times we have care homes who don't respond. They will accept the report, they'll tell us it's factually accurate or not, and leave it at that. Sometimes services do that. We sometimes don't get a full response that we would like sometimes. But we will publish, because once we're ready and we know the providers have seen it, they've signed it off in a sense of, they are saying, yep, this is factually accurate, it's their right to respond. You can choose to respond or not. We welcome a response. We think it's great. We think it's great for patients to know. It might be something. So, for example, some like with GP practices, sometimes we might say, is there a confidentiality room? You know, sometimes people want to speak in private, as you know, and then some GP practice, there won't be one. So we might put in, you know, you could consider having a space for a private room, and somebody might say, well, there isn't anywhere. There literally is nowhere. We will try and find somewhere if we can, and we'll put that in, because that's good for patients to know that it's not that the practice doesn't want to give a room. There might not be a room, or we might say, you know, at different days of our visit, the car park, people might tell us about car parking. It used to be our biggest thing at the hospital, love it. So one of the things we might observe is the car park, is there spaces, is there a good flow of people moving in that car park, is there disabled spaces, you know, we observe those things. Is it things people are mentioning to us, you know? So, but you can't change if you've got a car park or not, unless, you know, there's a building happening, and, you know, you can do that. But if it's something that patients have told us, you know, we will put it in. So it's a bit of just highlighting, you know, knowing what your patients think, what their irks are maybe, and then how we can, is there a solution to it? Is there not? There might not be. You can't magic a car park, but there might be different, you know, you say to people, well, there is the bus route, there is this, there is that, you know, there are different ways. So yeah, recommendations are just that, they're recommendations. Our reports do get shared, as Dawna said. We share them widely within our system. So if there are bigger things that we think need escalating, we will escalate. We will also loop back. So we aim to loop back within a year to see, especially if we put in some things that we know, you know, need looking at. And we will loop back and ask, particularly with like the example with ED with services, we might go and do a revisit. We might just go back to the practice managers or care home managers to ask, you know, did you make any improvements based on the recommendations? Have things changed? So sometimes, like with care homes, it can be, as Dawna knows, sometimes they might want an activity coordinator. There might be a need for transport. You know, one of the things sometimes looking for transport, they might tell us, we did manage to get a new coordinator because, you know, head office have read the report and now we've managed to secure something. Many moons ago, when we went down to, you tell I've been in this a long time, many moons ago, when we went down to the eye care clinic at the Royal, one of the things we noticed there was there was never a big sign. There was never a sign. Now there's a massive eye, and always been recently, so people can't miss it. One of the things on our Enter View visit, we were like, how do people know this is the eye? There was this tiny little sign, and so once we did our report, one of the things they got was this massive sign. And the other thing, that team at the time, so I'm going back quite a while, against our recommendations, they put together an action plan. So we did our report, they took the recommendations, they put together their own action plan and said, Healthwatch has recommended this. In order to do that, we need this. In order to do that, we need this money. They then put that back into the system, back to their own trust, into UHL, and UHL provided more funding to that department. So it can also be used as quite a tool to say, well, this has been identified. Can we make improvements? And then they managed to, I think it was about time, about an extra £70,000 they put into the department. Guess what we stopped hearing about for a while? The eye care clinic, because they'd made improvements based on the recommendations, which was really positive for patients. So there's ways to, we try and talk about the positiveness of going and doing a visit. And that's another way that it can actually have really positive outcomes. If there are areas that, you know, our reps observe, you go, how can this be improved? Or is this something, you know, that we can escalate elsewhere?
How many GP visits do you think you do within a year?
How many do we do, Dawna? How many have we done this year? Off top of your head.
About 23, 24, I think we've done this year already.
Of all EV, that's all Enter View visits, isn't it? How many GPs of that? Probably half?
Oh, GPs, about half, yes.
Yeah, probably 10 to 12 visits, I'd say, we've done so far. With a
few
few reports.
Far this year? Okay.
Yeah. So by this year, I mean from we run April to March. No.
Oh.
So from this year, I was thinking we're in like financial year. So we aim to do, so our aim is to do a minimum of one a month. So over the whole year, we would want to do 12.
Okay.
That's what our aim is. And that's the same as care homes. And then we obviously have a slightly different plan for our service visits because they're based slightly different. But that is our kind of running program. And we will be, the visit list we will determine in April, because that's when we start our financial year, to look at which places we're going to visit based on our intelligence, because that's what we're going to do now. Crunch the intelligence, see what people have been telling us about different services to determine where we're going to go next with our visits.
That's really helpful. And you talked about, I know that you guys cover Leicester and Leicestershire. Forgive my ignorance, but I presume there's a similar for Rutland.
Yeah. So Healthwatch Rutland will cover all practices in Rutland. So yeah, you can we do joint visits. So with the services, because a lot of our services cover LLR. So for example, like the eye care ophthalmology department we went to, reports come in, ED, so Leicester Royal, and the CAMS visit, they're all LLR reports. So we do try to do our service visits together if the patients using those services are covered by LLR. That's what we kind of do. But in terms of GPs and care homes and their local hospital, Rutland will cover those.
And you talked about you kind of actively share the report once it's kind of published with kind of stakeholders. How much do you think that had an impact on general practice then, kind of following those kind of things? Because obviously, there's organisations like the CQC and those kind of things. How much do you think that kind of influences them kind of visiting practices?
I mean, obviously the CQC have their own programme as well. I think for us, if there is something that we say, we will escalate anyway. So that's where we can influence. If we think something needs escalating.
When you talk about escalate, escalate to where?
To the Care Quality Commission. So say we go and do a visit, we're only observers. So if there's something we think needs a bit more investigating, so say for example, or say for a care home, people start telling us about medicine management or record keeping and things, that's not what we're there to look at. Or we get a general sense that something isn't right. You know, you kind of can pick up things and the team will go, something's not right here. We also work closely with the Integrated Care Board. So we work closely with the ICB. So again, with our GP survey, which I spoke about, we're working with them to review it. And the other thing we're looking at doing is doing kind of a bit more of kind of like these, kind of meeting more with PCNs, meeting more with the practices to get an overall feel of not just individually what working and what isn't working, but collectively, where do we think improvements could be made? So it's not, although each individual practice will look at look at the recommendations for them, sometimes it is wider things. We're looking at the themes all the time. So at the very beginning, we spoke about GP access. We hear it constant, the number one thing people tell us about, and we work in the system, US system, we know the ins and outs of that, but we're always thinking about how can we get this message across to the general public? What can we do to make them see the changes, see the improvements? How do we make them feel that, they can access their GP when they need it? It's all of that kind of thing. So we're working closely with ICB on that. So we'll be doing, we do lots of different ways, I'm
going to put you a bit on the spot, Gemma, if I don't mind.
That's all right.
So obviously you talked about themes within kind of general practice. Is there any themes that you can kind of share with us now that you feel that would kind of benefit all of general practice?
Yeah, so let me just, 1 second. I've just got where did I put it? We recently had our conference. So we recently had a conference to look at priorities. And one of those things we did, we pulled out, I don't know if I can find it, and then I will share it. Some of the priorities. And so I can share with you what people are saying, if I can just quickly find it.
Right, I think it'd be really useful just to see those kind of themes that could have a kind of a short, sharp kind of suggestion that practices could kind of consider, whether it's
1 second, let me just pull this up.
How do practices get the best out of their visits?
Do you want to answer or do you want me to answer?
You can answer.
Yeah. Well, I think it's about I've lost my screen. Hold on a sec. Open wider. Get the best out of the visit. I think the key is when obviously we make contact, it's find a suitable day. PPGs come along. I think that's really valuable because they're obviously working within the practice, supporting the practice, and give us some really good insights about what's working and what isn't working. Responding to the recommendations, that's really good. I mean, on the day, it works very well. Practice managers are really quite welcome us to the visits. We don't want to take up practice managers' time. That's really key, that, we want to be there doing the visit and then giving some clear feedback. Timely responses, I suppose. you know, just to say we're, you know, the report is, they're happy with it, that it's reflective of the day of the visit. I think we remind ourselves, I think it's a moment in time. You know, we're going in that period of time on that day. You know, we're not there to kind of, we're not looking, this is, I suppose this is the misconception, is to understand that with an enter and view visit, it's part of our staff responsibility, but we are looking for the good and the bad and the improvements. That's always what we're looking for, but we're not actively looking for things that are wrong. We're looking just to see, what does it look like? What do the local patients think of that service? And I think on balance, Donna, there's been some really good positive observations, feedback. And it is our representatives, local people become authorised representatives. So they are volunteers who do these visits, supported obviously by our staff team, but it is a layperson's perspective. Yeah, and that I suppose is sometimes the challenge, isn't it? To think, okay, who, you know, what is this? But let me just share my screen with you. We'll go back to the let me go back here. Everyone see. Oh, move this out of my way. Okay, so here we go. I can't see anybody now. So can everyone hear me?
Well, I can, yeah.
Lovely. So we were, as part of our priority setting for this year, and there is a survey out, and we can share that as well, actually, if anybody would like to complete and share what they think we should be working on next year. But these were GP access remains the #1 concern for people across Leicester and Leicestershire. And the 4 key issues, so all the data that we've crunched on this: difficulty in securing same-day or urgent appointments, long telephone wait times and challenges with the online booking system and NHS apps, shortage of doctors leading to reduced availability for face-to-face consultations, and issues with continuity of care, particularly for those with long-term conditions. So they're the 4 themes that have come out from GP access and what people tell us. I'll share the others as well, just quickly, so you can see what the 6 priorities have been for the whole year. Priority 2 is hospitals and emergency departments, no surprise. And again, people sharing concerns about quality of care they receive, long waiting lists, high on the agenda. People sometimes feeling they're not treated with respect, kindness or dignity when they're in the hospital. The long queues at the emergency department, and communication is a big one. So how well, if people get moved from departments, how well that communication is. No surprise again, dentistry. So people report their struggles with accessing NHS dental care, and the 4 key things there: the availability of appointments, high costs of private dental care, the long waiting times again for any essential treatments, and particularly we see in the city the impact on children and vulnerable individuals who struggle to get timely care. Mental health in young people and adults. So concerns again are around the long waiting times for referrals and diagnosis. So big thing that remains within support services. Accessing the CAMS services, some of the interventions, just why people are waiting, people reporting that long waits are leading into worsened conditions, the people feeling that the mental health support they're getting in schools is insufficient. Sometimes barriers people tell us, not knowing what services exist. So again, talking about how sometimes it's not that services aren't there, it's how do people know what exists and how to access it. The quality of care, the wait times, medication, adult social care. So another one, people are telling us about the concerns that carers have, whether that's supporting carers or care receiving care workers, care plans following hospital discharge. We're just doing a big survey at the minute around hospital discharge, support from occupational therapy, care received in care and nursing homes, and support from social workers. And finally, services for people with learning disabilities and or autism. So again, long waiting times, not knowing how to get support whilst waiting. Again, information and support may be there, but is it reaching people? Long waiting times for treatment once diagnosed, and not knowing how to access services. So say they are our longest.
They're no surprise, if I'm completely honest, kind of, Gemma, but
absolutely.
Obviously some of those kind of areas are not due to kind of general practice. They're kind of a wider kind of health at government funding and investment into these services, you know what I mean? And we kind of all recognise that obviously the funding investment into general practice has kind of decreased over the years, which has obviously had an impact, and the current contract has obviously not allowed them to be able to recruit GPs like they used to.
So with the Enter View programme, you know, the reason obviously we are tasked to do this as part of a local health watch is just to give some insights. It's there to provide insights. Say different people use the report in different ways. You can use it as a platform. You can use it just to share more with your local patients. We want patients to know what is available. We want patients to see, this is what my local practice do, and this is just, our observations on the day.
Thank you. It's really kind of helpful. I realise I've kind of I've said a lot. So if anybody has any kind of questions, welcome to put them in the chat. Welcome to put your hand up, or otherwise we'll kind of conclude this kind of meeting.
I was going to say as well, I think just looking, I know everyone's not got the cameras on because you're busy and everything, because we've been, I think, to looking at some of the practices. I think we've been to some of the practices recently or previously. So hopefully, I'm not pick anyone out, so everyone's busy doing things, but that you've had a good experience, and that you've been through that process. And if you're speaking to all the colleagues about it, to know that we work together. I think the other key thing is, we said it before, the report is between us and the provider before it's published. So it's not there to, if anything isn't right in that report, if our reps have not picked up on something from a conversation or an observation, we won't publish that because it's incorrect. It's not accurate. So it's meant to be an accurate reflection of the day of that visit, and that's what it is.
Thank you. And as I kind of outlined in the beginning of this kind of session, it was an opportunity to kind of highlight kind of obviously the kind of what you do and how you do it and that kind of thing, to give some kind of familiarity to kind of our practices. Because often they kind of get the letter or the kind of phone call to say they're kind of coming, and it kind of wants to try and familiarise it more with practices. So,
and I was just going to add, if anybody wants to join our mailing list, so you can see the reports when they come out, do let us know. Either email me or just go on our website and add your details, and then we can make sure that you're seeing some of the reports that are coming out from some of the visits that we're doing.
Okay, Julie, you've put your hand up.
Yes, hello. We had a health watch visit in January, and I just wanted to check on timeframes. You have touched on it slightly, but can you give me an indication from when the report comes out to when the practice gets an opportunity to respond, to when it's published on your Healthwatch website?
Yep. So I think that one is sitting in my inbox, Julie, to be honest.
Oh, is it?
I think I just seen the Charnwood practice. I think that is sitting today, actually. I think Donna has just finalised that, I think, with the reps today. So the process now will be that we will, I always do a sense check, first of all, just to check the typos, all that kind of thing. And then it will be sent to you. So you will get a copy of that for your right to respond. So you've got your 21 day window, we say about 3 weeks. So you can have a look at that, decide, is it factually accurate? Donna will put all this in the email for you. And then when it comes, once we're happy with it, you're happy with it, we're happy with it, it then goes to our board members. So all our reports are signed off by our board. And then once that has happened, we will then publish, and we will always send you a copy of it and let you know it's on the website and let you know that it's been published and it's out there.
Oh, that's very helpful. Thank you.
So from an inspection or a visit, so should I say, how long is it between the visit and the kind of the report?
It's approximately 12 weeks. It's approximately 12 weeks, taking out any, bank holidays, that kind of thing. But it's about a 12-week process between the visit, the report being drafted, then sending it to the provider. You say the time frame and sometimes it does take longer because some providers like to share it wider within their own organisation, because obviously it kept within provider. So they do have that opportunity there, and they might, Donna might message them and say, we need a little bit longer because X is on holiday, but we'd like them to see it before we agree the report. And then once it's agreed, it normally takes from our end, we try, all our board members, we will try and meet them within a 2-week window to get that report signed off, and then it will be published. But I say it normally takes about 12 weeks to do that. If it can be quicker, so if obviously report's drafted, ready to go, we get it to the provider as soon as it's ready to go. But sometimes it can be with provider longer than that 21-day period. Because we do like to put a response in. We do want to we have to have a response from the provider, even if they don't want to put a response in. So you'll see with some of our care home reports, we will put just a line in to say the provider has agreed that the report is factually accurate and has no further comments to make. And that's fair enough. But we want to make sure that they've got it, they've seen it, they know we're publishing.
Okay. Thank you, Gemma. Thank you, Donna. We don't have any more hands. So are you happy to share the presentation with me so I can circulate to the delegates? Is that okay?
Absolutely. Yeah, we will share a copy with you.
And what's the kind of the normal kind of process if practices want to kind of contact you? Is it your emails or is there a kind of generic? Yeah,
you can contact all our contact details. We'll send that with it. So Donna will share our contact details. We're all on our website. So either you can contact me or Donna directly, or you can contact our inquiries line, and we'll get access to those emails as well. They get filtered out to us as well. But yeah, you can contact us directly.
That's really helpful.
Yeah.
I will just thank you both for and thank you everybody else for your time. I know there's a lot more other people that wish to come today, but obviously not been able to get. So I'm just going to say thank you to you all, and we'll close the meeting.
Thanks all. Bye-bye.
Thank you. Bye.